Thank you all for having me. I'm excited to be able to be here today. I'm going to start because February was Heart Health Month, is kind of like halfway in between, with talking about pregnancy as a window into future cardiovascular health and future health in general. Next slide, please. So we can all work together to improve. Next slide, ish maybe. Health, cardiovascular health, and pregnancy outcome through working together with enhanced collaboration. Heart disease and pregnancy complications are kind of a two-way street. One causes the other, and like if you have an increased risk of heart disease, you have an increased risk of pregnancy complications, and the other way around. So lots of studies have demonstrated that certain adverse pregnancy outcomes are kind of important and gender specific predictors of long-term risk for cardiovascular disease. The main ones are preeclampsia, and we know that it affects somewhere between 6 to 8% of pregnancies. It seems like a lot more in our pregnant population. Fetal growth restriction, which is defined as less than 5 pounds, 5 ounces at term. Preterm birth, which affects 10 to 12% of pregnancies, and actually in 2022 was the first year that had increased in more than 20 years in the United States. And placental abruption. Women with high blood pressure during pregnancy or indicated preterm birth, meaning preterm birth that was for a reason because of high blood pressure or diabetes, have almost a 3-fold increased risk of chronic high blood pressure or chronic hypertension within 7 years of delivery, and some even before their child's second birthday. So my child's second birthday, and I'm lucky I didn't have preeclampsia, is in 2 weeks, and so that just seems like so crazy
level
to me.
1 trauma activation,
happening as trauma activation, time flies so fast. And almost half of women with high blood pressure in pregnancy and an indicated preterm birth become hypertensive by the time the terrible twos are over. A history of preeclampsia has also been shown to increase the risk of vascular disease, ischemic heart disease, hyperlipidemia or high cholesterol, diabetes, and thromboembolic events like pulmonary emboli and stroke. Next slide, please. This is a schematic that comes from the Society of Maternal Fetal Medicine, and they took it from a recent publication in hypertension that kind of, the top shows how pregnancy can be a window to future health by uncovering predispositions of chronic disease in women who develop a pregnancy complication. So the red line is population with complicated pregnancies like preeclampsia, and the blue line is a healthy population. The green line is kind of the threshold for when you would develop a clinical vascular or metabolic disease. So most people won't develop it until middle age, but during pregnancy, you kind of get closer to that threshold. And in B, you can see that early interventions, targeted screening, lifestyle modifications, and early treatment can kind of decrease the patients who have pregnancy complications back down towards those who don't. So what are kind of those targeted screening, lifestyle modifications, and early treatment, and how can we pick out those patients and utilize those modifications and treatments to improve the health of our pregnant populations during pregnancy, to improve their long-term health, because it doesn't matter just during pregnancy, but it matters over the course of their entire life. Next slide, please. Maternal mortality during pregnancy and in the early postpartum period, the main drivers are cardiovascular disease, including coronary artery disease, stroke, cardiomyopathies, high blood pressure, and cerebrovascular accidents. They're the leading cause of death in women. They happen in they're like responsible for 1 in 5 female deaths, and that's more than all cancers combined. So this is from 2011 to 2013. And since then, our population of pregnant patients has aged significantly. I know we all have noticed this and noticed this in our population and bear witness to this. And so this is only going to increase and be a major driver of mortality throughout the course of women's life or people with uteruses life and our pregnant population's life. Next slide, please. In 2022, in the New England Journal of Medicine, they went through pregnancy and decided what interventions can we employ to reduce the risk of preeclampsia? And they went through various interventions. Moderate exercise. What does that mean? It's different for every person, but at least getting your heart rate close to or somewhere near 140 beats per minute for at least 140 minutes per week. It doesn't have to be all at once. It doesn't have to be for 30 minutes. You can do it for 10 minutes here, 10 minutes there, but it has to equal 140 minutes per week. And that reduces your risk of preeclampsia by about 40%. Assessing risk for preeclampsia, if you have two moderate risk factors, and there's ACOG and United Task Force guidelines about this, initiate aspirin before 16 weeks of gestation, and it's more than 100 milligrams per day. So I always recommend in my pregnant populations to take 2 baby aspirins a day. I know everybody in ACOG and SMFM, not so much anymore, but ACOG is still recommending 81. And that's just extrapolating data from all the studies that were done in Europe and Brazil that are recommending 1 tablet a day, or recommending 100 or 150 milligrams. And we're just like assuming that 1 tablet works because that's what we have in the United States. So it's really 100 milligrams or more. That decreases preterm preeclampsia by at least 60%. Dietary calcium intake in patients with low dietary calcium intake, less than 900 milligrams a day. Taking a calcium supplement of 500 milligrams a day decreases preeclampsia by about 50%. So I tell my patients to take a Tums a day. They love it anyway because they all have reflux. Timed birth, delivering by 39 weeks in patients who have any risk factors decreases the risk by about 35%.
The room went muted.
100 milligrams at less than 16 weeks, and it showed at least a 60% reduction in preterm preeclampsia in the highest risk patients when it was started by the 16-week mark. Next slide. Some of the most traditional risk factors for heart disease are things like an unhealthy diet, physical inactivity, having an unhealthy weight, smoking, stress, which is very prevalent in our current lifestyle and society, alcohol and drug abuse. Next slide. And we have more novel and gender-specific risk factors for heart disease that include pregnancy-specific risk factors. So that kind of brings us to our new hot topic, that we shouldn't be just focusing on outside of pregnancy risk factors, but we should be including risk factors that happen when you're pregnant in your overall risk for cardiovascular disease. Next slide, please. This just goes through some of the various adverse pregnancy outcomes. APO stands for adverse pregnancy outcomes, and their associations with death and cardiovascular disease. And so things like hypertensive disorders of pregnancy, preeclampsia, gestational hypertension, gestational diabetes, preterm delivery, small for gestational age neonates, large for gestational age neonates, that's an association with gestational diabetes, placental abruption, miscarriages and stillbirths, and then just various other adverse pregnancy outcomes, and how much they increase the risk of atherosclerosis and associated vessel disease of the heart and heart failure. Next slide, please. The main ones that we're going to focus on are fetal growth restriction, preeclampsia and gestational hypertension, and spontaneous preterm birth. Next slide. And women with growth restricted infants have been found to be at least twice as likely to experience future cardiovascular disease, and the strength increases with increasing severity of growth restriction. So when you have the less than first percentile fetus with abnormal Dopplers and low fluid, that patient has is more likely to experience future cardiovascular disease. Next slide, please. This just shows some of the long-term outcomes after a patient with preeclampsia or gestational hypertension. So if you have preeclampsia or gestational hypertension diagnosed in your pregnancy, you're at about a double risk of early cardiac, cerebrovascular, or peripheral arterial disease, and overall cardiovascular mortality. And you're about a 4 times increased risk of congestive heart failure. And those are kind of things that are missed when you go to your cardiologist when you're 50 years old for your regular checkup. They don't routinely ask you, oh, when you were 20, when you were pregnant, or 30, when you were pregnant, did you have these things? So it's important now that we're collaborating with nursing and the cardiology team and our PCPs and our internal medicine teams to make sure that we're asking these important questions. Next slide, please. The most important thing about this graph that shows the increasing incidence of high blood pressure and the time since the birth in years is that you could see that a woman who had preeclampsia in her 20s has a higher risk of high blood pressure within 10-year delivery than a woman in her 40s who didn't have preeclampsia. That's like so remarkable to think about. If you're 20 and now you had preeclampsia when you were 20 and now you're 40, you're at a higher risk of having high blood pressure than a woman who is 40 and didn't have preeclampsia. That's a higher risk factor than obesity, than having diabetes, than being African American, than being of a low socioeconomic status. It's like a big deal and something that we're missing over and glossing over and not paying attention to. Next slide, please. So what are some of the maternal outcomes that we're seeing after patients who have spontaneous preterm birth? Not indicated like we're inducing them because of preeclampsia, but they just go into spontaneous labor at 29 weeks, let's say. The information and the statistics in the purple box come from a group of about almost 50,000 women that had about a 12.5 or 13% preterm birth rate between 1988 and 1999, with follow-up until 2010. And in this group of women, they showed a 38% increased risk of ischemic heart disease like myocardial infarctions or heart attacks, a 71% increased risk of stroke, and a 2-fold increased risk of overall cardiovascular disease. That is extremely significant. The second kind of section where I show the higher rates of simple and complex cardiovascular events was a meta-analysis of 10 studies from various European countries. And those showed a higher rates of simple and complex cardiovascular events in patients after spontaneous preterm birth and higher rates of total cardiovascular related hospitalizations. And the third part was a secondary analysis from the nurses studies from the 90s. And that showed after adjusting for pre-pregnancy lifestyle and traditional cardiovascular risk factors like obesity, socioeconomic status, use of hormones, other lifestyle risk factors, there was still a 42% greater risk of cardiovascular disease after having a spontaneous preterm birth. Next slide. So why are women with certain adverse pregnancy outcomes at higher risk of cardiovascular disease and death? Next slide. It's kind of complex. So there's an underlying inflammation and endothelial dysfunction that causes these adverse pregnancy outcomes that leads to cardiovascular disease. And pregnancy kind of unveils this. It's a stress test. And then there's this thing that we call a placental syndrome, which is why sometimes we send placental pathology. And the pregnancy complications show this endothelial dysfunction that is in the placental syndrome, and this lasting endothelial dysfunction causes this increased risk of cardiovascular disease throughout the life of the patient. Next slide. I'm actually going to skip this slide in the interest of time, but it basically says the same thing. So now that we know these novel risk factors for heart disease, we know that pregnancy complications have long-term implications for mom, and that pregnancy is kind of this stress test that unveils a predisposition for heart disease. Next slide. But it's also interesting that it does the same thing for the baby, because the baby's living in this in utero environment for however many weeks the baby ends up being in there. And this environment has, we kind of know like the fetal origins of long-term disease has this long-term impact on the life of the baby. And so when mom's not healthy, baby ends up being unhealthy, even for over the long term. Next slide. So there's this hypothesis called the fetal origins of adult disease, and programming can generate permanent changes that persist throughout the life span. So what happens inside the uterus influences the patient throughout the baby's lifetime. Next slide. I'm going to focus on the mom because I am the Healthy Mama Doc, but it is kind of a wake-up call for moms and even their babies, because, and it's a reason why I can sometimes get my moms to focus and control their blood sugars better and control their high blood pressures better, because I say, listen, this isn't just for you and your healthy pregnancy, is for your baby too. It's to help make a better environment to grow a healthy child and adult, not just have a healthy pregnancy. Next slide. There is some good news and not just horrible statistics. There are interventions in life events that can bring down the risk and bring it back down to normal, or at least closer to normal, and can, next slide. So it's kind of this window of opportunity for women. Next slide. There is a documentary titled Misdiagnosed, and it was edited by our very own Stacy Rosen, who the other day was chosen as the American Heart Association president, which is so cool. And she's so cool. And if you don't know her, you should find out about her. She is amazing. Cardiovascular disease is under-recognized in women, and this documentary kind of shows all about that and goes through that. And delayed implementation and prevention strategies exacerbate that problem. And all of these types of heart disease, because of later presentation and more severe disease, cause a worse prognosis in women compared to men. So there's more deaths in women because they show up differently and we don't treat them as well. And so it's very cool and everyone should watch this. I think it's on Netflix. Next slide. Early diagnosis and intervention can prevent about 80% of cardiovascular disease, which is a lot. Next slide. So what happened in your pregnancy shouldn't be like locked up in forever in your obstetrician's all script chart. And like once we close out your prenatal record, it shouldn't be just forgotten. It should be remembered. And your nurse and your primary care provider and your cardiologist and your pediatrician and everyone in your life should be aware of your pregnancy complications, and especially the patient themselves. But it really starts with you all. I can't not stress that enough, because it's just like the reminder, and you all are the ones at the bedside more than anyone to be like, hey, how's your cardiology appointment going? Have you made it yet? Good job. And we can really prevent tragedies if we suspect and diagnose and remind these patients to follow up and remind them of their disease earlier on in their life. Next slide. And focusing on better postnatal cardiovascular assessment after a woman experiences these adverse pregnancy outcomes can alter their disease trajectory and improve their women's heart health. It's more than just saying, oh, eat a better, healthy Mediterranean diet and make sure you exercise. Like, these patients really do need to follow up and start taking statins and reduce their blood pressure and have their echocardiogram. And next slide, go to the Cardio-Obstructive Center. We have this awesome center in the Women's Heart Health Program at Feinstein, and it's a partnership between cardiology, MFM, and OBGYN, and we send our patients there. And I know everyone's probably heard of it, and if you haven't, now you have. And it's like a program for early identification and modification for risk factors for heart disease and stroke based on pregnancy outcomes. Next slide, please. And patients should be referred if they have any pre-existing cardiac disease coming into a pregnancy, are trying to conceive or considering pregnancy. So if they are lucky enough to self-refer themselves or get referred for a preconception consult, and anyone who is thinking about pregnancy, even if they're super healthy, should have one. If they had preeclampsia or hypertension in a previous pregnancy, if they had spontaneous preterm birth, or if they've had any problem in their pregnancy, just go see them. It's fine. Get an echo. It'll be great. The phone number to refer patients is 562-4100, or you can email them, Cardio OB, they're on Global, or you can call me, or you can Instagram me, or you can just do anything and send your patients there. It'll be awesome. Next slide. In the program, they do these steps. They screen for them, the risk factors like that we discussed. They assess, and then they kind of work on aggressive risk factor management. Like, they implement lifestyle modifications. They use the American Heart Association Simple 7 lifestyle risk reduction. They manage blood pressure. They control cholesterol with statin and other medications. They reduce blood sugar. They help patients stay active, eat healthy, help them lose weight, and definitely encourage people to stop smoking and other types of tobacco use. And then they estimate risk and treat accordingly with consideration of sex-specific risk factors. So it's tailored to women and people with ovaries, trying to be politically correct. They assess their 10-year and their lifetime risk, and they treat them early and they don't wait for symptoms to come. Next slide. That's what I have. I know it's like fast and furious, but I'm trying to share with the colorectal.
Thank you.
Prevention. That's my Instagram. I post a ton of stuff about preeclampsia, heart health, pregnancy, trying to conceive. Come visit and send your patients there. Thanks for having me.
Thank you. Dr. Molmenti joining us. Thank you so much.
Hi, everyone. Thank you very much for having me today. I greatly appreciate your invitation. I'm here today to talk about an important topic, women and colorectal cancer prevention. And this is a topic that we are bringing to center stage because it often gets overlooked amidst the emphasis placed on reproductive health, on breast health, which are very, very important as well. But we're trying to bring colorectal cancer up onto the same stage so that we can save our female patients' lives. Next slide, please. So working with our team at Northwell, we have been working on this colorectal cancer programming for the last 8 years. And we've made a lot of progress, but we're not there yet. So we continue to do our work with a number of partners, internally and externally. And today I'll share with you the background on why we're so focused on women and some of our initiatives. Next slide. So to start, colorectal cancer is the third leading cause of cancer death among women. And when you look at women under 50, it's the second leading cause of cancer death. Colorectal cancer just incidentally has moved up to the leading cause of cancer death among men under 50. So we've really seen this rise in early onset disease. As of 2024, the new ACS report, you also see that the trends overall in colorectal cancer in women are starting to slow down. We've seen large declines since the advent of colonoscopy in the 80s, but that is now the flattening of the curve is starting to occur when we look at incidence and mortality of colorectal cancer. And we're starting to see a 1% increase per year since 2011 in our population. So this is something to take note of. Next slide. So one of the other reasons we're so focused on colorectal cancer is because the number one risk factor is age. So in the census data that you're looking at on the right are females in blue, and you'll see this is from 1980 to 2020 to 2060. And as you can see over time, not only will older women continue to outnumber older men, but for an example, and you're looking at a group of 60-year-olds, there's going to be more women in that age group. And so if colorectal cancer increases with age, we have to think about how are we going to tailor messages to that population? How are we going to increase access to screening? And what other resources do we need as our population continues to age? Next slide. In addition, minority women are at highest risk. So you'll see here that non-Hispanic Black women are actually at the highest incidence rate, but the other racial and ethnic groups are not far behind. So this is a very important group. We also know by 2050, white women will no longer be the majority in the United States. So we'll have more minority women. There are some early data to suggest minority women only see an OBGYN as their primary care provider. So if we're going to get messaging to women, we can't always rely on the internal medicine primary care setting, but we really need to talk to the OBGYNs. They may be a critical source of information for women. Next slide. So another important population is young women. So we see about 20% of colorectal cancer cases in women under 54. And on the right, you'll see a female patient here, stage 4 colorectal cancer, 3 young children. And she's a perfect example of what we're seeing more and more today. It's not so uncommon for a woman in her 30s to hear the words, "You have colorectal cancer." And a lot of female patients and young patients in general see multiple providers before they get the right diagnosis. There's been surveys conducted to show that their symptoms are dismissed. They don't even know their symptoms to get checked, and they're diagnosed at very late stages as a result. Next slide. So the takeaway here is really that too many females are being diagnosed at late stages when their survival is lowest. So when colorectal cancer is caught early, 5-year survival is over 90%. But when we start looking at regional and distant metastases, survival over 5 years is 15% or lower. So it's a very important topic that, this is why we're laser focused on women. Next slide. So I'd now like to take you through sort of the why. Why is this happening? And there are a lot of different factors to consider. The number one factor is screening. And when we look at national screening rates among women, they're low. So we know that 34% of women haven't been screened by any screening test. So that's over a third of women. We also know that women prefer female endoscopists, and some women prefer stool-based screening tests. And as we know, stool-based screening is excellent if that's the only screening you do, but it only detects cancer. It doesn't prevent colorectal cancer. Only colonoscopy can prevent colorectal cancer through the removal of polyps. And this is very important when we're talking to our women about their screening options. There's also some data to suggest that women have more barriers related to anxiety, embarrassment, also thinking about childcare, getting time off. There are a lot of barriers that are very specific to women that we really have to uncover. Next slide, please. So there are other reasons why we're potentially seeing this higher mortality in women. Number one is that the complaints among young women especially, number one is abdominal pain and hematochezia. And when we talk about abdominal pain and factors that can resemble menstrual cycle findings, it's so easy for those symptoms to be overlooked. And this is what they're attributed to a lot of times. So this is an important piece. The second piece is that females are more likely to develop right-sided colorectal cancer. So when you think about the colon and the colonoscope having to go all the way around to the right side, you see a lower chance of getting a complete exam, and polyps are missed in their early stages or cancers. So there's more right-sided disease and a higher risk for flat polyps and sessile serrated lesions in women. And those obviously can sometimes not be distinguished on a colonoscopy and can be missed. So these are sort of the tumor biology pieces of it and some of the symptomatology that is unique to women. Next slide. So at Northwell, and given this background, we've really identified 4 goals for how we want to tackle early on colorectal cancer in women. So one, we're developing service line collaborations, increasing awareness among our providers to increase screening rates. We're conducting clinical and epidemiologic investigations to really understand the why, the barriers, and how we can make change. We're also identifying female patients at high risk so that we can get them into on-time screening and improving access. And then also we're partnering with national organizations to have, be part of the national agenda. Next slide. And within these goals, we're 3 focus areas. There's early onset colorectal cancer, like I mentioned, women under 50, minority populations, and our pilot program. And another piece to think about with women, more and more they're becoming heads of households. And so if we can educate women, we have an opportunity to really educate the family, because they're going to disseminate that information among their spouse, among their children. We really have to get the information to them in the most engaging possible way. Next slide. So we have assembled a multidisciplinary and multi-departmental effort really to work on this programs internally, externally. And just wanted to put this slide up to call out to some of our key organizations, the Katz Institute for Women's Health, that has funded our research since 2020. The Northwell Health Cancer Institute, where we also have a Clinical Innovations Award working with Cold Spring Harbor to understand the molecular pieces of this. And then a number of partners in the health system with gastroenterology and the Department of Medicine, the Feinstein Institutes for Medical Research, the Cancer Institute. So it's been a big effort through the health system to move this forward. Next slide. So now I'm going to take you through just two of our big initiatives. One is OBGYN to GI. So we are trying to get into the OBGYN practice and really find first of all, our average risk women who are 45, no family history, colorectal or polyps, cancer or polyps, and no symptoms. So next slide. So Dr. Victor Klein came to me and said, we have all these women in our waiting room. Why don't we just see what they're thinking? They're sitting there anyway. We can give them a survey. So we developed a very short survey. It's 10 questions. We've collected over 2,500 surveys so far since August at the 600 Northern Boulevard practice and some at 865. So next slide. And this is, you can't see it that well, but it's just a 10-question survey asking women for their, no names, but just their age, race, ethnicity. Have they been screened for colorectal cancer? Do they have a family history of colorectal cancer or polyps? Have they been screened? If not, what are the barriers? And then how do they see their OBGYN visit? Is it just primary care or do they have another provider? Next slide. So I'm going to share with you on some of the results. So just basically in these waiting rooms so far, it's predominantly white population. But we do have some other racial and ethnic groups represented. So we're trying to break those data down so that we can look differently at women based upon their race and ethnicity. Next slide. The mean age was about 45. But we're really focused on looking at our average risk women, 45 plus, and then our high risk women who are 40 plus, who have a history of colorectal cancer, and they check that box, or a family history of colorectal polyps. So in this population, there was a percentage that were average risk, a large percentage, 38% of average risk women not screened. In the high risk population, 20% of those women who check the box, family history, they're 53 years old, not screened. So this is a big opportunity. Next slide. But what's most telling are the things that I'm going to read to you next, which is why haven't they been screened? And everyone always says it's the prep, it's the prep, it's the prep. Nobody wants the prep. But
Nobody wants the prep.
And they still don't. And they still don't. But what we're finding in the waiting room survey, at least, is that we're upstream from the prep. Because the number one reason here is I didn't know I needed one. Why haven't you been screened? I'm not 50 yet. Well, the screening age is now 45. My doctor never told me. My doctor told me next year. So there's an awareness issue that we're really trying to uncover with this data. And then we'll get to the prep. Once they know they have to be screened, and then we can talk about that as a barrier. So this was among average risk women. Next slide. But we also saw this about among our high-risk women, those that checked other, which was a high percentage, 38.5% of the samples checked other. 30% said, I didn't know I needed one. And of those who checked other, it wasn't recommended by my doctor, have one coming up, trying to make an appointment, things like that. So next slide. So as a solution, we are just launching, as of tomorrow, at 1554 Northern Boulevard, a new program where we are helping patients self-refer into colonoscopy. So this is a tear sheet that we created with the Katz Institute for Women's Health. Colon screening is right in the middle. At the top is breast cancer for mammos, and the last one is lung cancer screening. But we are decided we want to put this into the hands of the patient. We started this program giving the doctors a link on their desktop to go into a REDCap database and get them into Northwell's Fast Track program. It was a little clunky for some OBGYNs, so we said, let's put it in the hands of the patient. So we are testing this starting tomorrow, and over the next 2 months, we're going to see how many patients referred in, how many got a colonoscopy. There's a navigator that calls them within 48 hours of them filling out the form through the QR code. They do a risk assessment, make sure that they don't need a consult first. If they're Fast Track eligible, they go straight into Northwell's GI system, and that navigator helps them schedule the visit within a 30-day period, gets the prep, sets them up basically, kind of holds their hand through the process. So this is something very excited. We're just launching tomorrow. Tomorrow's the go blue month.
You may have stated this. How is it being disseminated?
So we're giving it to the MAs. So we gave 10 pads. There's 10 providers there. Each provider will have their MA sort of as the keeper of this tear sheet. It's going to be like a pad. So after they do the vitals and they're waiting in the room for the provider to come in, they can, look at that sheet, scan the code, and they can start to fill out the form while they're waiting for their provider to come in. That's how we're doing it. We don't want them to put it in, like, we're not giving it at registration. We're afraid it's going to go drop in the bag, then it comes back up. So we kind of want it in their hand when they really have nothing else to do and they're waiting.
And they have their phone.
They have their phone and they can do it all right there. Yeah, so we're excited to see how this turns out. Okay, so we have a quick poll here.
Yes,
And-
and answer time.
So what are the most common barriers to colorectal cancer screening that you hear from patients?
The
QR code.
It's the QR code.
Oh, yeah.
QR code.
Oh, yeah.
I'm gonna copy this.
Okay, so it looks like the prep.
Oh,
It
in
looks like
room with the prep.
It looks like the prep. So, offline, it'd be really nice to dive into this a little bit more, but that's very interesting. But again, this is among women that probably know they need to be screened. And this is an issue that we also want to tackle, which is the prep, develop a female-oriented prep, make it in a lavender box. Women a little bit more and give it a better name.
Go to the next
So
question.
next question, what are the most common barriers to colorectal cancer screening that you yourself have experienced?
Enough time, too busy.
Oh, yeah. So not enough time, too busy. Again, working professionals, working women, working men. It's very difficult for a lot of people to get that time off.
Embarrassment.
So and embarrassment is another piece of this. So thank you for doing the poll. Hopefully we can save these answers later. So just quickly, our next initiative is focused on high-risk patients. So now I said, we're going to figure out who are average risk women. Let's get them into screening. Let's improve access to the program. Now we're talking about high-risk patients. These are people that have been diagnosed not with colorectal, not that have a family history of colorectal cancer, but a family history of polyps. So next slide quickly. So the national guidelines state that if you have a first-degree relative, parent, sibling, child with colorectal cancer, you're at risk and need to be screened at 40 or 10 years before your relative's diagnosis. When a person's diagnosed with colorectal cancer at the time of endoscopy, typically the family members get phone calls that they've been diagnosed with colorectal cancer. But the same guideline states that if you've been diagnosed with an advanced polyp, a polyp that's a centimeter or more, or has certain histological features, your family members also need to be screened at 40 or 10 years prior to your diagnosis. The same recommendation as if you had cancer. But no one picks up the phone and calls their brother or their sister after a colonoscopy that they had a polyp. So this is where we are going full steam ahead at Northwell, which I'll tell you a little bit about in a second. So next slide. So there's a lot of evidence to state, why this is so, especially when someone has a polyp with high-grade dysplasia, or if it's large, or if it has villus components. This is where you see this up to 20-fold increased risk in their siblings to also have an advanced polyp. Next slide. And so we've been publishing on this quite a bit. If anyone wants more information, we have data that is easy in that we're developing for the public. That's on the American Cancer Society website to increase awareness among our providers, because this is overlooked in GI as well. Next click, and this is just definition, and next slide. And so recently we said, okay, here's the pie chart of patients diagnosed with colorectal cancer. And right now the data is showing us about 70% of cases are sporadic, meaning no known family history, no genetic inherited conditions, but sporadic. So in people under 50, 10% is due to family history. I'm sorry, 15% is due to family history, and about another 15% is due to having a genetic mutation. But this 70% may not be fully 70%, because there might be a portion of those that have a family history of polyps that were never identified. So we had access to the Ohio Colorectal Cancer Prevention Initiative at Ohio State University, where they conducted the statewide study, and we had access to 536 people under 50 with colorectal cancer. And so we contacted all 536 people, all patients. 30% were deceased by the time we had the cohort, so we contacted next of kin. We collected the names of all their first degree relatives. We collected 280 names, and then we called all the first degree relatives. We asked them, did you have a colonoscopy before your loved one had colorectal cancer under 50? From there, we were able to call those endoscopy suites for anyone that had a colonoscopy. We collected all the records. This just wasn't in Ohio. These people were everywhere because they were relatives. And then we found at the end of it that there was an 18% rate of these advanced polyps in these people under 50. There was a female patient with a mother who had an advanced lesion. I think it was this 1 centimeter or 2 centimeter polyp in 1998. And she was diagnosed with colorectal cancer at 40 or 45. And that could have potentially been prevented. So next slide. So what we're pilot testing right now at Phelps and Lenox Hill is a program at the time of endoscopy to identify these patients. And we have endoscopists at each site, Phelps and Lenox Hill. We developed a tear sheet. Next slide, I'll show you that tear sheet. Well, go to the next slide. And so at the time of endoscopy, patients get a tear sheet. On the first side, it's for them. You were diagnosed with an advanced polyp. You have earlier screening and surveillance recommendations, but this also has implications for your family. And they flip it over, and on the other side is a QR code. It says, please give this to your family member. They need to be screened at 40. And then we write their age at the top, or 10 years before your colonoscopy. So if they're 38, their family members need to be screened at 28. And we're writing it in 28 and giving them the QR code so that those relatives don't just have to find a GI somewhere, but this links them into a Northwell navigator that will schedule the colonoscopy for the relatives of these advanced polyp patients. So this is one thing we're going to also have some data on in the next couple months. Okay, next slide. I think I just have 2 quick clinical scenarios. So this is for everyone's just a little bit of a test. So this on the left here is a 61-year-old white. Oh, these are switched.
Oh,
But it's so on the left is an asymptomatic 39-year-old African-American female, 39. She had a father with an advanced polyp at 67. What should be communicated to this patient?
Get this
to next year.
Yeah.
40.
Well, you can tell, all right,
For
you can
this
tell
woman.
us. They're gonna get both questions.
Okay,
So they
fine.
can read
So-
them, yeah. You want, hold on, let me scan them first.
Okay, so for the 39-year-old African-American female, so because she has a first-degree relative with advanced polyp, she should be screened next year at 40 because of her father's history. And and if she has siblings, they should also be screened. Both answers, actually,
Both answers.
For the 61-year-old female patient with a 1.1 centimeter tubular adenoma, for her, again, she has to communicate to her children if she has any, to her siblings if they haven't been screened yet, and talk to their physicians about getting screened early.
So we did about 50.
Benefit of having
Yeah, we did about 50.
Thank you.
So we got,
Okay, so that's
50 we did. Okay.
Excuse me. Yeah. Next slide. And we're almost finished. I'm going to wrap up now with just some of our Go Blue initiatives. So March 1st starts Go Blue Month, Colorectal Cancer Awareness Month. Next slide. We are holding a symposium in Westchester. If anyone can come, it's on March 21st, half day in the morning, on early onset colorectal cancer. We have a speaker from Memorial Sloan Kettering talking about her work in rectal cancer, which she's actually been able to show great results in reducing rectal cancer prognosis progression in these young patients. And then we're also doing a CATS colorectal cancer webinar coming up on March 12th. Both of these are free events. Next slide. And then we have a number of different things going on at Northwell, which you'll see through the month of March. Digital screens. We have a lot of collateral, which we brought here today. We have a health risk assessment. If you go to the Go Blue landing page on CATS Institute for Women's Health website, you can do a risk assessment. And again, we have a landing page with all of that information. So in conclusion, just wanted to thank you for allowing me to share this valuable information today. When we raise the health of women, we raise everyone, as I mentioned. I have a few slides on the CATS Institute for Women's Health. Sharon Zarabi is here. She's the CATS Institute for Women's Health Director of Program Development, soon to be the Director of Operations tomorrow. And we have a lot of information to sign up as ambassadors. If you'd like to participate more in the CATS Institute, we'd love to have you. So if you just want to scroll through the next couple slides, you'll just see these are CATS slides. We're breaking the mold in female care. Next slide. And this is just showing CATS is more than just North Shore and LIJ when people think it's really just maternal and child health. A lot of expansion across Northwell. Next slide. There are a number of ways to get involved. Like I said, being an ambassador, getting involved in the women's circle. Sharon can explain all of this. And next slide. And staying connected with a number of different events, website, webinars. There's tons of things going on with the CATS Institute for Women's Health that are free and you can participate in. I was going to leave you with a video very briefly that we created for our female patients.
Next week. The video or? Yeah.
Yeah, there we go.
At that time, I was 43.
I probably should have went at 50, but I turned 51.
I mean, I was 38 with colon cancer, so I want to yell it.
Proper screening can prevent about 90% of colorectal cancers.
The cure is catching it early.
If we catch cancer in its earliest stages, lifetime survival is over 90%.
You know, look at me. I'm relatively young. I'm in pretty good shape. I have no other pre-existing conditions, and I just happened to go in for a checkup. And I came out with stage 3 rectal cancer.
The number one symptom of colorectal cancer is no symptom at all. It's very easy to kind of forget about these things because you feel fine and there's no urgency to get it done. But that's exactly the opposite of what we want. It's worth it to do these colonoscopies because enough of the time we find something.
I think the biggest fear about it is, number one, having to do that prep.
It wasn't as bad as I thought it would be. I thought it was going to be like this big gallon of something that tastes terrible.
It's really not bad.
Really isn't that bad. And then the procedure itself is nothing. I mean, you're not even awake.
It's the best 30-minute nap ever.
realizing that it's not as bad as they thought it was going to be makes them much more likely to comply the next time and to tell their friends and family that they should then go out and get a colonoscopy.
The cool thing was how many of my girlfriends did it. 3 of them had polyps that they got taken out right away. So that was a pretty cool feeling.
Patients who have a family history of colorectal cancer or certain polyps, they need to get screened at the very least at age 40, sometimes even younger.
Be mindful and get yourself checked out if necessary.
If you're not sure, ask your doctor. It's not something to be scared of. It's not something to fear. And we hope that everybody goes out and gets it done.
It blows my mind, I think almost daily, that I'm like, I had cancer, but I'm just back to living, you know, because I got it early.
So with that, just like to thank everyone for your time.
Thank
And
you.
if any
So
questions, I'll be happy
powerful.
to take those.
Thank you. Anybody have any questions?